Hello, this is Dr. Clark, and this is Principles and Methods of Drug Administration, Chapter 3 in your book. This chapter, we're going to go over the different ways that we administer drugs, some of the basic things that we do when we do administer drugs. All drugs should be considered as potentially harmful or toxic to the body, and we take care when we give them, and we make sure that they're in the proper dosage range for the patient, that they're the proper drug, that they're not a drug that's going to be harmful to our patients. Because some drugs you can't use in some species without causing harm. And so some of the things that we kind of look at is administration of the appropriate amount of drugs. So making sure that total dose that we're giving is appropriate for that animal. Making sure that introduction of the amount of the drug into the body is the appropriate route, and also making sure we're giving them the right amount. And then also making sure that the drug is introduced in the animal's body, the proper way, so that um, if you try to give something that's meant to go IV, IM, so in the vein, accidentally in the muscle, you can have a problem, or something that's supposed to go in the muscle into the vein, you can also have problems with that. So those are some very important things when we're looking at drugs usage and safety. We want to make sure that preparing to administer medication, that we have a very clean environment that we're drawing up and using our drugs in. We want to be sure that if they've been sitting on the shelf for a while and with an open top that's not been sealed, that we clean it off with either some sterile water or saline to get any dust off of it. Sometimes when we actually go and stick a needle in to pull medication out, we'll change needles before we go and actually inject it in the animal. We also want to make sure if we're dispensing pills on a dispensing tray or something similar to that, that we want to clean that tray between prescriptions, because you might put an antibiotic on there that an animal has an allergy to, and then you turn around and put something with Rimadyl. Well, that antibiotic residue can get on that Rimadyl, and you could cause a anaphylactic reaction in your patient. So we always want to make sure that we clean those items when we're doing any pills dispensing to where we don't get any cross of residue. Need to have all your proper supplies on hand. We don't need to be searching for them. If it's going to be stuff that's injectable, we want to make sure our syringe and needles are all sterile. They're properly handled. If a needle accidentally touches something like your arm or the counter, we're going to take that needle off and put a fresh one on there. And then make sure that when we're doing it that we have proper lighting to see. There's nothing like trying to look at a tuberculin syringe in a dark room and trying to figure out if you've got a tenth of a mil. And sometimes a tenth of a mil can be very significant, especially dealing with anesthetics. So we want to make sure we have proper lighting, and we want to have minimal distractions. We don't want a bunch of people coming in there and trying to bother us or be in the busy part of the hospital. So when we do these pulling up drugs, we want to try to keep staff interruptions to a minimum. If they have questions, they can wait until you're done. We also don't want to be where all the heavy traffic is, or where you have a TV or anything loud that would distract you from doing your job. We try to keep where we're handling pharmaceuticals at as quiet and stress-free as possible, so you can concentrate on doing it right the first time. You need to know all the components of the drug order, and so drug orders are not that are not complete, unclear, or it seems like the dosage or the amounts outside the recommended range, should be questioned and should be through closed loop. If I say, I need 12 milligrams of epinephrine drawn up for this animal in cardiac arrest, you need to say, uh, are you sure you're needing 12 milligrams of this drug? And because that might be a dosage error, I might be needing 1.2 milligrams of that drug. So clarification and closed loop communication is important to make sure. And so it is important to actually know your dosage, and you're part of the check and balance system. Anytime that we do any drugs, we like to have it checked at least twice, preferably 3 times. If you go into the human hospital, doctor gives an order for a drug, it's going to be checked by the nurse and usually a second nurse to verify before it's given. We like to at least have a check and balance of twice. So there's nothing wrong with you verifying that this is the correct dose. It's not questioning your doctor. If any veterinarian gets upset about that, then you're probably working for the wrong veterinarian, because all you're doing is you're verifying that you have the correct information, then making sure that you have the correct calculations, because we all do make mistakes. And then verbal orders need to be documented. They need to be documented as far as what the drug is, the dosage, what the total dose you gave is, the route that it was given, and the veterinarian doing the order for it. And of course, there's also things like the time that you gave it, and making sure you document it's to the right patient. And that's what we'll get into next, is the 6 rights of drug administrations. And so this is always making sure that we do the right drug at the right dose, at the right time, by the right route to the right patient, and the right documentation. So when you go to document something, we're going to document the name of the drug, either the trade name or the generic drug, what the dosage is, so how many milligrams per kilogram, the total dose that you gave. You can also put down the volume in milliliters or in tablets that you gave, the time that you gave it, the route that you gave it, making sure that it's the correct patient. And then you're going to actually document all that. And if it's an oral verbal order, you're actually going to also go back and write down which veterinarian actually gave you that. That's very important. Here, there's only one veterinarian to deal with, but if you're in a multi-veterinarian practice, it's important to put down which veterinarian actually gave the order for that drug. So, the right drug, we always go and confirm. We're going to look at this 3 times on standards. We get OCD in this business, and we do things in 3s. And so one of the things we're going to do is we're going to make sure that we have that right drug, and we'll actually check that drug 3 times. We're going to check the dosage 3 times through our calculations, at least twice by yourself and once by somebody else. We're going to check and make sure that we're giving it the right time. So if it's supposed to be BID, which is every 12 hours, we want to make sure that we're giving it at 12 hours and not at 6 hours or at 18 hours. Right route, if it's supposed to be IM, making sure it's going IM and not IV or sub-Q. Right patient, and this is something, if you're in a busy practice, you might have 10 chocolate labs in the back of the clinic. And so making sure that you have them identified, the patient, both in the record and your orders, and then on the patient itself. Here we use tags around their neck, paper tags that we can identify them with, and cage cards. You want to make sure that you actually have those in place to where you can walk into that kennel area and say, okay, I'm supposed to be giving this to Fido Smith. And so I'll go back there and look, and out of 11 chocolate labs, I'll find the one that has the name tag that says Fido Smith. A lot of times we'll also put like patient numbers, if you have that available, on the tag, and make sure that all that matches up before we give the medication. So right patient's very important. And lastly, right documentation. And so this documentation is going to be that I gave this drug at this dose through this route at this time to this patient. And then you're going to initial beside it. And you're going to do it as soon as you do the medication to the patient. You're not going to wait, because this reduces errors. And this is one of the most overlooked but important things. And we have had issues here time to time with it, with patients accidentally getting a second dose because somebody gave the first dose of medicine, forgot to document it. Somebody came by and said, oh, that has not been done. And they give it again, and they document it, and then they come back later. Well, I already gave the first one. We're short. And I gave the first one. Well, they didn't write it down. They did that wrong. So you want to write it down in the record. Or some clinics have like these little cage checkoff sheets for medication times with check boxes. As soon as you give that medication, you want to initial in that check box. You don't want to just check it off. You actually want to sit there and initial it. And so here what you do is you actually write it down that you've done it, and you'll actually initial beside it in the patient record that you actually gave that medication at that time. So the right drug means that the patient's receiving the drug that was prescribed. The label container said we should actually read it 3 times to make sure it is the correct drug in the correct concentration in the correct form. There can be differences in concentration. You might be looking at prednisone. And so prednisone can come in a half a milligram, 5 milligrams, and 20 milligrams. I might have a prescription for 5 milligrams. If you pick up 1 milligrams or 20 milligrams, that's the wrong container for that patient. So you want to make sure that you verify that, and we check it 3 times before we administer it. We also want to know why that patient is receiving that drug. So what condition is it receiving it? And part of this actually helps us determine, is the drug being effective, or are we having side effects due to the reason that we're giving this drug? What's going on with it? If we ever come across a container that's unlabeled, we don't use those drugs. We remove them. Sometimes people will draw up something in a syringe, set it to the side. They don't remember what it is. You don't remember what it is. That gets chunked. If you have a pill bottle back there and there's no label as what's contained in it, we get rid of those. Right dose is making sure that the dose prescribed for the particular patient is the right amount. And so both the veterinarian and the technician should calculate each drug dose accurately, making sure there's no orders. And, a lot of times when you're calculating drug dosages, when you get doing these a lot, you're usually pretty good about knowing about the drugs and about how much it's going to be. Like when you get done with anesthesia and surgery for 6 weeks, you'll probably pretty much be able to look at them and guess, I should be in this neighborhood. And if you'll see if you get off that you're like, whoa, that's off, let me go recalculate it. And if you're in doubt, always have somebody double check your math. We like to see the math done at least twice, and then have somebody verify it just to make sure. Right time, so time is specific, and so we have the proper levels, and that we don't accidentally get, if we give it too soon, we can actually get toxic levels. If we wait too long, we can actually get out of the efficacy of time of that drug. If a drug's supposed to be given, say, every 8 hours, and you gave it at 7 hours or 9 hours, probably not a big deal. But if you gave it at 4 or 6 hours, or if you waited until 12 hours to give it, it's supposed to be given every 8 hours, then that becomes much more of a problem. So we try to make sure that we're as close to time as possible. If you have one patient in the back of your hospital, it's very easy to be on time. If you've got 20 back there, you usually start a little bit early trying to get all your medications done and documented, because it takes quite a lot. So it just depends on what your caseload is. But we try to get as close to the time as we can. Route, and this also goes with techniques, so making sure we're administering at the proper technique for the route. If you're giving it orally, it's making sure if it's a pill that they get it. You can use it either in the food and making sure that they swallow it. So we actually have these little pill things that they put in that's like a treat that they can chew up and swallow. Sometimes we actually open their mouth and force it back and pill them with it. If it's IV, making sure it's going IV and making sure that IV is patent when we do it. If it's IM, making sure it's in the muscle. If it's specific on a muscle, like miticide is for heartworms, that it's in the proper muscle that's labeled for. If it's sub-Q, making sure we're in the sub-Q area. So wherever it's supposed to be at, making sure it's in those areas. It's important to use as aseptic technique as possible when you're administering them. Of course, if you're doing an injectable, you want to make sure that you're doing it as cleanly as possible when you do them. There is some controversy whether or not we do need alcohol. There's some studies that actually show that it maybe disturbs some of the bacteria on the skin a little bit more and brings them up. There's others that show that there's really not any difference between them, so it's kind of veterinarian's preference. I myself am one that I don't use alcohol because I got entrenched, and I've actually never had any problems doing injections without alcohol and causing any infections. But I had some professors that had actually worked on some of those studies about alcohol actually disturbing bacteria and potentially making the chance of abscessation higher. So you just have to follow your veterinarian's protocol. That's what I do, but somebody else will do it a little bit differently. The other thing when you're looking at this, if you just handled a dog that's had vomiting and diarrhea, the last thing you want to do is go in there with dirty hands and potentially contaminate that pill and cause that. So, we want to clean our hands between patients and between medications we're giving to them, and making sure it's in the right site. So we kind of talked about that. Some of these will actually be specific to the sites. Right patient, so it's actually going and making sure the cage card, their identification card, and what you have in your records all match up. If you have 2 Fido Smiths, then we go further and we see what the first name is. And if one owner is Adam Smith and the other one is Jane Smith, is making sure it's Fido Adam Smith and not Fido Jane Smith. And said we can also use unique identification numbers also for our patients and use that to help us decide if we have the right patient. But we always want to verify that, and we want to verify that once again 3 times. A lot of times when we verify things, you're going to see we do rules of 3. We verify it all 3 times. And then the right documentation. So the drug, the dosage administered, the time and date we administered, the route. If it's injectable, the site that we gave it. So do we give in the right leg, the left leg, the withers, the left semi-membranosus and tendinosis, the left tricep muscles. So wherever we gave it, the right epaxials, any patient responses, and then whoever the veterinarian is that ordered it, and then your initials out beside it. Or if it's already in a standing order, so if it's already been written down per my order, then you just put your initials out to the side that it's been performed. This kind of comes down to a legal and safety obligation. So first off, if you didn't document it, it didn't get done. So this actually proves that the drug was actually given for a court of law. It also proves it from the legal aspect of the state. The state says we have to document all these things. And so if an inspector comes in and they're like, well, there was a prescription for this drug, but I see it was never given, we can actually get in trouble for that. So legally, this protects us on two fronts. From tort, from litigation, also protects us from the regulatory agencies. And then it's the safety obligations. It's making sure that you're doing what's safe for your patient. If you have everything properly documented, when you gave it, it keeps them from being dosed a second time and potentially having an adverse reaction to that or a drug toxicity. It's also communication between different professionals in this profession. You might be treating this dog, the owner might get a better job in, say, Cincinnati. They're going to go work for WKRP in Cincinnati, and so they're going up there and they're taking their dog. Well, the new vet and the new technicians need to know what's going on with that animal, how they've reacted to certain medications from certain procedures in the past, how they were administered. And so you're giving them a record of how that is. So it actually keeps a better continuum of care for better care for your patients. You can go back and look at that. You can also put in there and document if there's any refusal of treatment by the owner. And you can also include the reasons for the refusals. Maybe it's cost, maybe it's the fact that they don't want to do it. But this way, if they actually refuse a medical treatment, we have documentation of that in case the patient gets worse. We can say, well, we wanted to do this, but you refused to do that. All drugs should be considered potential poisons and should be dispensed and used with great care. And we look at what we call a therapeutic range. So this is going to be a range between something called minimum effective concentration and minimal toxic concentration. So when you go above the MTC, the minimum toxic concentration, this is when there's actual toxicity to the patient from the drug. It turns into a poison. MEC, or minimum effective concentration, this is a level the drug has to cross to actually be effective. Below MEC, there is no effect to the drug anymore. You're really not getting any effects or any clinical actions from the drug when it's below MEC. The idea is that therapeutic range is between that minimum effective concentration, but yet below that minimum toxic concentration. We want to keep it right in between there, and that is our therapeutic range. There's factors that are involved with this, so route of administration, drug dosage, and drug intervals. These all play roles in therapeutic range. We get a little bit more into that into Chapter 4, but if we're giving something IV, we get a much more initial spike in the effective therapeutic range right there. So it comes up really quick. It's also easy with IV to actually accidentally get in the toxic range. So we have to make sure our dosage is right. But if we give something IV, it's going to be a lot more effective, but it's going to last shorter. So we have to redose it at a much more higher frequency of interval there for your drug dosage. So if you give it IV, you might have to give it every 4 hours IV. An example of this is penicillin. So when we look at our IV penicillins, which are sodium and potassium penicillins, these usually are dosed about every 4 to 6 hours. On the other hand, we might give something intramuscular, and that route of administration will verify the dosage on it. And the dosage interval, because of the absorption of the drug, is a little bit different. And so our procaine and benzocaine penicillins are for IM use only. They only go in the muscle. And we usually dose those, there's two different formulations, once every 12 hours or once every 24 hours. depending on which one that you get. Usually procaines every 12, benzocaine's every 24 hours. And so it's very important to make sure you're staying in these intervals, or you can get toxicity or other untold effects. And so these are major things that we keep in mind, is by the route that we're giving it, uh, the amount that we're giving, and then how often we need to give it. Um, your quickest amount of drug that's going to be available is going to be IV, then IM, sub-Q, and then lastly oral. So oral is the slowest. However, duration of action is going to be slowest for IV. Next slowest is going to be IM, unless it's actually in a time release suspension, then sub-Q, and then definitely the longest duration of action is going to be from oral drugs. They take longer to be absorbed in the body, and they take longer to also clear out. Routes of administration. So a parenteral drug is given anything other than oral. So we have oral medications or gastrointestinal tract. Pretty much if it's going into the stomach, it's an oral medication or into the mouth. Actually, rectal is actually considered parenteral and not actually oral or gastrointestinal. So parenteral includes things such as IV in the vein, IM in the muscle, sub-Q in the subcutaneous space, interarticular, which is IA, interarterial, which is also IA. You can give it topically, transdermally, interdermally, so an interdermal is going to be like our tuberculosis testing. Transdermal is going to be like fentanyl patches. Topical would be any type of medication you just put on top of the skin. And rectally is also considered a parenteral route. Factors for choosing the route is, the drug causes an effect when given parenterally and not orally. Or maybe we get a more rapid response. Other insoluble drugs can be given IM, but not IV. So anything that goes IV has to be able to be dissolved in water. But things that are oil-based or emulsive-based can actually go in the muscle. There's drugs that are actually destroyed by the acids in the stomach. And so we cannot actually give those orally. There's an example. There's ivermectin. There's an oral form that we use in horses. There's an oral form that you use in HeartGuard. There is a buffer for it. So when you give that ivermectin and it goes through the stomach, it can make it past the stomach acid and be absorbed in the small intestine and be effective across the body. However, a lot of people want to go out and get the injectable cattle wormer at the store to give for heartworms for their dogs because it's cheap. And they give it by mouth. Well, the problem with that is when that gets to the stomach, it's not actually buffered and protected in the injectable form. It actually breaks down and dissolves, and the animal does not get any of the ivermectin. So these are the common parenteral routes are going to be IV, IM, sub-Q that we give. And then we can look at things like aqueous solutions, which are water. These can go IV, IM, or sub-Q. Or emulsions, which are going to be mixed with some type of oil mixtures. And so your emulsions are going to usually go IM or sub-Q. They're usually more time released. Generally speaking, if you can't see through it, it doesn't go IV. A couple of exceptions to that is Solu-Delta-Cortef, which is a potent corticosteroid for anaphylactic reactions, and propofol. Propofol is white. It kind of throws all of us off when we give it to induce, but it's actually an aqueous solution and it can go that way. But generally everything else you should be able to look through and see through fairly easy. IV drugs have a very rapid onset. They have a very high initial loading dose in the body and very high peaks, but much shorter duration of action. So they have to be redosed frequently. A lot of times we'll use IVs for bolus administrations to give one-time large doses and then come back with oral medications or IM. Or we can use it as intermittent therapy where we give multiple doses over every 4 hours or 6 hours or whatever is required. Or we can do constant rate infusions. We hook them up to IV fluids. We have a fluid pump. We put the drug in there, and then we tell it to give this drug at this rate for the next 6 hours. So there's several different ways we can go with IV drugs. Almost all of them should be given slowly. Some of them we can give rapidly for like anesthesia for induction, especially in horses. We kind of give xylazine and ketamine relatively fast, but most of the rest of them should be by a slow push. And we try to minimize the air bubbles when we go and inject it to make sure we don't have an air embolus. You know, if you have a mill of air or something, that's going to be a problem. Sometimes you can't get all the air bubbles out. If you have some really tiny, small air bubbles, we're not worried about those. But if you have something that's half a mil or more, that's an air in there, it can cause an air emboli. It goes to the lung, and it actually will, that air pocket will set up and actually block blood flow to part of the lungs. And then you can actually get a pulmonary embolism, which ends up becoming life-threatening. IM drugs have rapidly fast onset, so IV drugs, we're usually looking back here at them having an onset within minutes, and usually less than 5 minutes, usually 2 or 3 minutes or less, sometimes even just a minute. IM drugs are more like 5 to 10 minutes. They have a relatively rapid onset, a longer duration of action than the IV drugs because they have to be absorbed through the muscle. And it depends on your formulation. So there's some IM drugs that have a shorter duration of action because they're aqueous. There's others that are in emulsions or have oils, and these can be time released. And these can actually be as long as days that they're released from the muscle, that they're slowly absorbed. So absorption depends on how we actually prepare these. And one of the things here is they're talking about solutions versus suspensions. Solutions are usually going to be clear. Suspensions are going to be made more of solid particles, and they're going to be harder to see through. So solutions are usually the ones that are fastly absorbed, and then your suspensions are the ones that are usually going to be take a lot longer to be absorbed. They're going to be more time released. Sub-Q, slower onset of action and longer duration than IM. So usually if you get something sub-Q, it might take 20 minutes before it starts to kick in, but it's going to last a lot longer. And so absorption rate, once again, can be changed versus aqueous versus some type of suspension or emulsion. One thing about sub-Q is you can actually give larger amounts in sub-Q than you can muscle. So in muscle and small animals, usually like 5 milliliters to 10 milliliters, depending on the size of the dog, is the most you can do. Sometimes it's less than that, like in little chihuahuas, you know, it could be 1 or 2 mils. Sub-Q, we can do like up to 60 mils without a problem. So we can put larger amounts in one area. The other thing is in large animals, we're actually in food animals, we can actually use pellets sub-Q for certain growth promoting hormones. One thing to know is that absorption from the sub-Q space can actually be manipulated through temperature. So if you want to increase the absorption, apply heat. If you want to slow it down, apply cold. This is important, especially if we're working with animals and they're hypothermic. You're going to have a much slower absorption of these drugs from the sub-Q space versus if they have a fever. Or if you're working in large animals and you're trying to give an antibiotic and it's 4 degrees outside and you're up in South Dakota, that's going to totally absorb totally different than if you're down in South Texas and it's 110 degrees in the shade. Those drugs will be absorbed a lot faster. So you can have a lot more effect of your environmental temperatures on the absorption of sub-Q drugs. Intermammaries, these work in the mammary gland fairly fast, and they have a fairly even distribution. We do these for certain antibiotics and certain drugs that we need to get in for mastitis, and they get in a lot quicker that way to take care of mastitis. They say it results in lower concentrations of drugs in the residue, and the slide's kind of wrong about that. So initially, you're going to have a higher concentration once you actually go into the mammary gland. And because you're putting the drug right there and it's going to stay there. Now the thing that will happen is with subsequent milkings you can actually remove more of that drug through the milking, whereas if you give it systemically on some of these drugs, it might take a week to clear with systemic levels, but putting it in the udder and then milking it back out, we can probably get it cleared out within 3 days. So we can clear the concentration a little bit faster by going intermammary, but the concentration of the drug's actually going to be higher because you're putting the drug directly into the milk. Other things that we look at is there's inhalation that you can do, so nebulizers. We can do this for certain respiratory diseases. Topical medications on top of the skin or the mucous membranes. We can do this with oral glucose on the mucous membranes for hypoglycemia. Antibiotics like Neosporin we'd use topically all the time. And there's a whole list in the book in Table 3.1 of the different ones of IV, IM, sub-Q, intermammary, interperitoneal, something that we do a lot in lab animals. So we can't get a vein on them, but we can actually go in the abdomen and in the peritoneum, and that's how we do it. We can do epidurals, we can do epidural catheters, and we can give things in the condylar spinal cord. Usually we're looking at things for analgesia when we're doing that. There's sometimes that there's some antibiotics that they'll use for some forms of bacterial meningitis, but most of the time when we're looking at doing it, we're looking at something to kind of block the hind end from pain and any feeling for a surgical purpose, or if like to pull a calf during a dystocia. That's when we're going to look at doing epidurals. Interarticular, which is IA, was inside the joint. We do this a lot for arthritis in horses. Also, IA is interarterial. We don't really do that many interarterials, but there's the occasions where we do. And usually when we do these, the ones I'm most familiar with is distal limb perfusions in horses. So we put a tourniquet on the leg of a horse that has an infection in the lower leg that we're having a really hard time treating. We cut off blood flow, we put a catheter into the artery, and then we fill up that part of the leg with antibiotics and literally let it sit there for 30 minutes with the antibiotics, let it soak in the capillary beds, and then we restore blood flow back to the leg by removing the tourniquet. You can do an intercardiac. That's not done that much anymore, but there was a time that we used to. Probably the biggest thing is for euthanasia is intercardiac for animals where we can't get a vein on. Intradermal, this is pretty much for tuberculosis testing where we just go into the dermis itself. And intermedullary or interosseous. So if we can't get an IV, we can go into the bone marrow in the long bones, and we can actually go in and put fluids and drugs through that way, and it's picked up just as fast as it would be through IV. Rectal administration is an alternative for giving drugs. We use suppositories like this for constipation. Also, the other thing is in animals that are in status epilepticus, meaning they're having a seizure and it's so bad it won't stop and we can't get an IV catheter, we can actually give them Valium rectally, and it'll actually be absorbed across the rectum. We usually double the dose of it from what the IV will be, and it takes a little bit of time, but it'll be absorbed enough to actually stop the seizures. A lot of times that rectal therapy can potentially cause to local irritation, so there can be some straining after you do these, potentially some diarrhea, a little bit of bloody stool with fresh red blood. Usually it's transient and it goes away. Vaginal administration, we pretty much do this in cattle for synchronization of estrus. So we'll actually implant certain hormone sponges or rings in there, and we're trying to actually synchronize the cow to come into heat at a certain time to make it easier to breed them all at the same time. Absorption can be a little bit poor, but we're doing this pretty much for hormonal reasons anyways, and so usually we have enough hormones in these rings to where it's not a problem, or these sponges to where there's enough within them to where they're going to absorb the proper amount vaginally. And so this kind of describes some of the different things that go on as far as formulary factor, physiology, age of patient, stage of estrus. Stage of estrus does play a role in it because if they're in estrus, there's more blood flow to the vaginal area. It's picked up a little bit faster. But a lot of our different things are actually for releasing progesterones intervaginally, and we use a lot of the sponges and stuff. Instead, it's used for synchronizing cattle, the one that it's most commonly used for. A transdermal across the skin, these are patches. The most common ones we see is nitroglycerin. We don't use that as much in veterinary medicine. We do use fentanyl patches though for pain. The main thing is we have to make it to where the animal cannot pull off the patches. So usually the place that we put these intradermal patches on or transdermal patches on is going to be across the withers, up there around the shoulder blades on the top, where we put front line and different spot-on treatments like that because they're actually not able to get around there and lick or chew or try to pull it off. So oral administration, any drug that's actually given directly into the mouth or into the stomach before entering the bloodstream, it actually has to be broken down and absorbed by either the stomach or the small intestine. And it's important to understand which type of drugs do which. Usually if it's a powder or a tablet, it's going to be broken down and absorbed in the stomach. If it's in a capsule or a gel cap, Those are meant to pass through the stomach, and they're going to break down in the small intestine where the drug will actually be absorbed by the small intestine. You also have suspensions and emulsions too. So you have aqueous suspensions that when you take them, they're going to be absorbed by the stomach. Some of your emulsions with fats that you can get to take orally, those are actually going to be broken down when they get to the small intestine, and the drug will be absorbed there. So a lot of times it depends on where we're looking at taking these up from. All these are going to be absorbed across the intestinal tract, and they're actually going to have to pass through the liver and be biotransformed into a form that the body can actually sit there and use. And so it'll actually pass through the liver. The liver is actually going to sit there and activate the drugs, because the drugs are not going to pass across in their original form. They're actually going to be broken down, slightly digested, and then they're going to cross through, and then the liver has to go back and put them back together into an inactive form again. And there's a slower rate of onset and action with oral drugs, and absorption rates can be affected by different factors in the intestinal tract, different drugs. If they're on acids, it could totally change the way something's taken up. If they have gastrointestinal disease like irritable bowel syndrome, diarrhea, something like vomiting, or an infection, that can actually affect the absorption of the drugs too. When we look at dose, dose is going to be the amount of drug that's actually administered. So there's a difference here between dose and dosage. And so the book here is actually going to sit here and describe the difference between them. So dose is the total amount of drug that we give. So loading dose is the initial dose. Sometimes this can be twice the therapeutic dose or maintenance dose. Sometimes it's the same amount as the maintenance dose. So we're looking at total milligrams. So if we're giving 5 milligrams of the drug, that is the dose. A loading dose might be giving them 5 milligrams IV, and then maintenance would be 5 milligrams per os twice a day. Or we might do something like 20 milligrams IV, followed up with 4 or 6 hours later, 10 milligrams IV. And so your 20 is your loading dose, and your 10 is your maintenance. We take all the dosages that we've given in the day, we add them all together, and that ends up being total daily dose. And this is the total number of milligrams of drug delivered within a 24-hour period. Drug dosage is the amount of drug per the animal's body weight. So this is in mgs per kg is the most common. Sometimes we'll get mgs per pound, but generally it's milligrams per kilogram. So dosage is this is how much the animals get in milligrams per kilogram. So to get the dose, we will take the milligrams per kilogram, multiply it by the kilogram of the animal's weight, and you will come out with the milligram dose for that animal. Dosage interval is how often we give it. So SID is once a day, BID is twice a day, TID is 3 times a day, QID is 4 times a day. If it's more than 4 times a day, then we're going to say Q and however many hours. So Q 4 hours is every 4 hours. So QID is every 6 hours. So if we need something every 4 hours, we don't have anything for 5 times a day, so we call it Q 4 hours. Or Q 2 hours or Q 1 hours, that's your drug interval. Your dosage regime is the interval and the dosage put together. So something like down here they've given 2 examples of saying 5 grams per pound BID, so you get 5 grams of a drug per pound of body weight twice a day, or 30 milligrams per kilogram TID, so you give an animal 30 milligrams per kilogram 3 times a day, and that would be your dosage regime. Drug toxicity, there's several different reasons for this. One of our biggest ones is human error or accident, which is human error most of the time. An accident would be like an animal getting into some medication and chewing and eating it all like a puppy. And once again, that's sometimes really attribute that back to human error, because if you come to think about it, we probably left it in a place a puppy could get to it, chew it on it, and ingest it. Toxicity might be related to side effects of the drug, and so some different types of drug toxicities are going to be outright overdose, so we outright gave too much of the drug, relative overdose, and so things can affect relative overdose such as patient's age status. Other sick conditions going on which makes the drug more potent. Other drugs that increase the potency of the drug. Seeing side effects of the drug. Accidental exposure to drugs, so once again, the animal maybe got into its own medicine and took too much. Interactions with other drugs, so other drugs can potentiate a drug and cause toxicities. And then incorrect treatments. We're actually giving the drugs for the wrong reason. So these are some examples of why we get into drug toxicities. Counteracting drug toxicities, you have to be able to recognize these fairly quick and act on them fairly quick. If you're giving something orally, the quickest thing you can do is make them vomit. If you're giving them a medication, so it's sitting there and giving them something like apomorphine conjunctivally will actually make them vomit. We actually put a little bit on their eye, it makes them start to vomit. When they're done vomiting, we just rinse it out and the vomiting stops. We can give them hydrogen peroxide, and that will make them vomit, and we try to get it up. If it's something like an acid, then we don't try to make them vomit up an acid. That's more toxicology though, and a lot of times if we have something like that, we can do milk or water form. The solution to pollution is dilution. The other thing that we can do for any of these is give them activated charcoal to bind the drug and to stop it from being absorbed. And a lot of your activated charcoals have cathartics, which actually help increase GI motility and get that to clear out the drug. We can actually enhance removal of drugs by diuresis, by giving them fluids, making the kidneys work more efficiently, trying to get rid of it. There's certain drugs that we have antidotes to that we can actually give that will counteract that drug. And then symptomatic care, watching them and treating issues as they come along. If they have arrhythmias of their heart, treating the arrhythmias. If they get dehydrated, giving them fluid therapy, assisting them in making sure they're eating. So it's doing good nursing care for a lot of these until the toxicity is actually passed and diminished. So that would be chapter 3, and we will see you in class and lab.